Right. Well, again, good morning, everyone, and welcome to our quarterly meeting of the Pennsylvania Cancer Control, Prevention, and Research Advisory Board and Cancer Coalition. So just as mentioned a few moments ago, just some tips for housekeeping. We are already started. And again, just if you are not on mute, if you can go ahead and make sure you are on mute. We will save questions till their designated space throughout the meeting, just to kind of allow for that designated time. But as mentioned here, you can designate the chat for a place to place questions or dialogue throughout the meeting today. That's also the same place if you are experiencing any technical issues, if you want to type them into the chat and someone will assist you. All right, so I'm going to turn things, I should have, my apologies, said that I'm Kate Mostowski. I'm going to turn things over a moment to our kind of welcome in this morning, but just to kind of run through the agenda, we will have our call to order and to kick us off and then go through a pretty healthy agenda for today's time, our final meeting of 2020, it's hard to believe, and really great content today. So we're really excited to get this started, and officially I am going to pass the baton over to Kelly, who will take us through our first few points on the agenda. And Kelly, I will advance your slides based on your lead. So thank you. I'll turn it over to you.
Thank you, Kate. I would like to take a moment to introduce myself in case you didn't meet me on our previous call. I'm Kelly Holland. I am the Director for the Bureau of Health Promotion and Risk Reduction at the Department of Health. I'd like to welcome everyone to our final CAB meeting of 2020 and officially open the meeting. I also wanted to let you know that I will be running the meeting today as Peg O'Grady, our Vice Chair, could not be with us today due to a staffing emergency at her facility. Next slide, please. So I'm not going to read this. This is just our conflict of interest statement. It's on the screen for everybody to read, and it was also in the agenda that Sharon had sent out to everybody. You can go ahead and advance. So just a note, as Kate mentioned, this meeting is being recorded and the recording will be made available for future reference. Meetings of the Pennsylvania Cancer Control, Prevention, and Research Advisory Board are public meetings under the Sunshine Act, and there is no expectation of privacy during these meetings. And the recording of this meeting will be housed on pacancercoalition.org for future reference. This next slide is just a shows our meetings for 2021. All meetings will continue to be virtual, and this schedule of meetings is also available on pacancercoalition.org website. All right, next slide. So next we want to take a moment and in recognition of Nathan Werth for his hard work and service to the Data Advisory Committee as co-chair. Nathan will continue to be a vital member of the Data Advisory Committee, and his expertise in helping to set cancer plan goals and identifying data sources has been invaluable, and he continues to be a great resource as we utilize data to monitor achievements of these plan goals. Nathan has taught us how to access data and make it an essential part of what we do. And Nathan will continue to be a member of the advisory committee, as I said, but Wendy Aldinger will be assuming the role of co-chair as of January 1st. So Nathan, we want to thank you for being part of our cancer control planning and implementation team. All right, so next is the CAB annual report. So Sharon had sent this out to everybody for your review, and sorry, I'm getting all kinds of notifications. So per the legislation, CAB members are required to report annually to the Governor and General Assembly on cancer control activity and the results achieved. And so today we are asking CAB members to give their approval of the draft that was sent to you for the 2019-2020 Cancer Prevention and Control Report. And then upon review of this report, it will be sent to the Secretary of Health and then on to the legislature. I don't believe we have a quorum today, but we will get approval from PEG through email. And so does anyone have any comments on the annual report, or can we approve this?
Yes, Kelly, this is Dr. Dominic, CAB member. I have reviewed the report and we approve it as written, and I make the motion to approve the report.
Suzanne Gollin, CAB member. I second the motion. I'd like to know how many CAB members are on the call. And I believe that the CAB members emailed Sharon with our approval of the report already. But we can have a motion during the meeting. But how many CAB members are on the call, please?
Good morning.
Dominic is present.
Nicole Blanard's on.
Suzanne Gollin is present.
So let the minutes reflect that the report has been presented. It's been motioned to approve by Dominic and second by
Second by Suzanne Gollin, please.
correct. And if quorum is not reached, then we will continue to establish quorum, and we will have PEG follow up with that. Thank you.
Thank you very much. Sharon, does that meet your needs for the report?
Yes, and all CAB members are present.
All right, thank you very much. Next slide, please. So next I'm going to ask our CAB member, Aurelia Dominic, to give a brief update regarding the video production of that the CAB had approved in September.
Thank you so much. I want to thank everyone again for attending today. I hope you had a wonderful Thanksgiving and getting ready to have a safe holiday. I would like to follow up with the disparities video that we had previously discussed. I would like to mention to you that we are going to continue with this project. We will be moving forward, and we will be connecting with each and every one of you, since this is a CAB led video. We will be having technical assistance from the Department of Health. Monica Fisher will be working with us for this video. We will also be leveraging our existing partnerships that we have here within CAB, as well as with the PCC. And we will be also leveraging our resources, including our data and data center. We want to make sure that what we convey in the video is accurate, it's readable, user-friendly, and that it does represent the cancer burden, as well as effective strategies that would encourage Pennsylvanians to talk to their doctor, to visit their doctor on a regular basis, and to take action and to get screened. We will also align closely with the Department of Health in terms of priority areas that tend to have disparities identified, as well as these disparities that remain persistent over time. And there are special populations. These are for racial and ethnic minority communities, as well as rural and urban, as well as LGBT communities. And we will also be working very closely with the commissions that the governor has put together to make sure that we have the presence of all groups, including veterans, including Asian, Indian, Pacific Islanders, Latinos, and women, and basically aligning ourselves, leveraging all resources that we have. These leveraging capabilities require a zero budget. It's just more collaboration and having what we call an all hands on deck approach. And we will also be leveraging our data as well as any existing reporting that either Nathan has provided or Sharon. She also produced some videos with highlights and with key points about cancer burden throughout the state. And we will also be highlighting existing documents such as our cancer plan and even the Pennsylvania Cancer Coalition. They have approaches and partnerships and a wonderful platform to exchange information and even for the identification and utilization of resources. So we in CAB are very well positioned to move forward with this health disparities or cancer disparity video. And I'm happy to announce that we will be moving forward with the project. Our timeline for designing the video and piloted testing it with many of you, and when it actually is released for public, we anticipate this to be within Q1, Q2, Q3, and again, releasing it at the highest quality and having the video explain the efforts of the CAB and the PPC as related to cancer health disparities. And we will be reaching out to each and every one of you to see how you are able to help us with the dissemination of the video, of highlighting key areas throughout Pennsylvania. Again, we will be focusing on the Department of Health 6 regions, which combined do represent the 67 counties, but these will be region highlights. And finally, I want to just remind you what the goal of the video is. And that's number one, to raise awareness of and the interest in the CAB and the PCC. The second is to describe the magnitude of cancer health disparities here in the Commonwealth. The third is to portray these experiences of individuals and organizations that are affected by cancer. And then the fourth would be to describe and enhance the efforts, not just of the CAB and the PCC to address the disparities, but each and every one of you that's on the front line in trying to have cancer prevention, treatment, or control. Again, our vision is the video will be made available to the general public through posting on various websites, in public venues and presentations, and we will need you. We will need you to also be champions for this and also be highlighted in the video as appropriate. And we will, again, be describing stories of how cancer affects individuals, as well as the communities, their families, and in the communities that they live in, and all the supply chains that interact with individuals in Pennsylvania, whether it be businesses, insurers, employers. So I thank you again and expect emails periodically from us directly to you again, thanking you for your ongoing support and for the vehicle that you will and the role that you will play in making this disparity cancer video in Pennsylvania well received and, more importantly, well put together. So thank you for your time.
Thank you. Are there any questions on the video before we move on? All right, if not, to the next slide. All right, thank you. Next, I want to turn it over to Jalila Parker for her update.
And nothing happened. Good morning. Thank you. Good morning, everyone. Again, my name is Jalila Parker, as it says on the slide, and I serve as the Executive Director of the Governor's Advisory Commission on African American Affairs, as well as the Southeast Regional Deputy Director. I just want to take a moment to thank Sharon and Monica and the coalition for inviting me to your meeting today. Looking at the agenda, I was a little overwhelmed, but honored that I'm in the same space as you guys and your expertise. So I think I have a couple of slides that you guys are going to advance for me, I was told.
Yes, correct. I will, based on your lead, I will.
Oh, okay, well, I'm ready. I'm ready.
Okay.
It's all right. So we can skip that. I introduced myself and said my greetings. So we can go to the next one. And although this was slated as a presentation from me, I expressed to Sharon and Monica that I really felt most comfortable engaging in that dialogue or a conversation with you guys. I am not a subject matter expert when it comes to health disparities. You guys are, especially from healthcare. And because race and racism talks can be uncomfortable for some, I just wanted to establish some safe space rules here. And also just say that, there's no sole possessor of knowledge. Although I am here representing the commission, my viewpoints are coming from my lived experiences as a Black woman, raising a Black son, married to a Black husband, living in the city of Philadelphia. I also will share with you viewpoints from stakeholders that I speak to on a regular basis, but my thoughts and ideas are based or are generalizations because Black people are not monoliths. And, but I am just going to kind of share some things. I just want to put it out there. I don't pretend that I'm speaking for every Black citizen in the Commonwealth of Pennsylvania. I want us all to take risks every day. I think you guys provide an essential service, and the things that we're encountering and going through right now, we all need to challenge ourselves and push each other. And again, just respect each other's feelings and opinions and recognize when there is an ouch moment. And sometimes that ouch moment can be painful. And then other times that ouch moment is more of a aha, an enlightening or realizing that you're not the only one in the room. So next slide, please. So as mentioned, the governor has 5 what we call affinity commissions housed in his office, representing different constituency groups. I have them listed here. Of course, African American Affairs is one of them. The commission is comprised of 20 members, 20 volunteers that are appointed by the governor for a term of 2 years. And all of our commissions, although we represent different constituencies, are charged to advise and advocate on behalf of our respective communities. So for my commission, their sole responsibility is to advise and advocate on behalf of African Americans in Pennsylvania. The commissioners themselves represent business owners, entrepreneurs, teachers, nonprofit leaders. We are half male, half female, and we run the gamut in ages as well. So our youngest commissioner, Ms. Jeter, I believe is about 26 in her late 20s, and our oldest commissioner is well in his 80s. So next slide, please. Each cohort of commissioners, and this group has pretty much the governor's first term, so for 4 years, sets the agenda and focus. And so I have here listed as kind of the things that this group has decided to hone in on. Because again, when you have a broad charge to advise and advocate on behalf of the Black community on any and everything that the state touches, you got to streamline some of your work or it can be overwhelming. So this cohort has decided to look at economic development and investment, which just is saying, opportunities for business owners, Black business owners and entrepreneurs to do contract work with the state, opportunities for them to work in our emerging industries and our regulated industries, so casinos, medical marijuana, and then the ease of them having access to capital to start a business or have their business grow. I'll skip the next one for now, but education funding. So we advocate for fair funding and equitable funding. So instead of just saying, we're going to send, $1,300 per child to each school district, what we want is for the budget to reflect the demographics and needs of a school district. So you may be a smaller school district, but if you have a large population that requires special services, whether that's English as a second language or health needs, that should be weighted in your school district. Your funding for education should come with that in mind. For voting rights reform and modernization, voting is part of the one last institution we have here where one vote, one man. So everybody, no matter what your class, sex, gender, once you turn 18, you have one vote, one man per election.
One person.
One person, yes, one person each election. So, we want to keep the integrity of our voting system, but we've also been pushing for some reform and modernization and trying to get the state to do same day voter registration, to allow, a time span, which we saw with this Act 77 this past election, a time span for people to exercise their right to vote. And making sure that everyone that's eligible knows. So Pennsylvania is also one of the few states that if you were criminally justice involved or if you had a felony conviction, once your time is served, your voting rights are restored. And we want to make sure that that is maintained. Criminal justice reform, we look at it from a comprehensive approach. So not just, a lot of times you'll hear in the public where people are talking about sentencing or probation. So we, of course, are looking at sentencing models, we're looking at cash bail, but we're also looking for, clean slate legislation. So making it easier for people to expunge their records, making it easier for people to recontribute to the society by gainful employment, by banning the box so that it's not on the state's job application anymore. And then also looking at policing. So what are we doing around policing? How diverse is our police force? The governor only has jurisdiction over state police, corrections officers, and park rangers. But this past summer, he actually started through executive order a civilian law enforcement review commission. So we are excited about that, which will explore matters of policing in the Commonwealth. So next slide. Oh, well, yeah. So unfortunately, up until now, and it was on the previous slide about racism as a public health issue, the commission didn't really take up health or healthcare matters. We do have one commissioner that operates a nonprofit that advocates for women's reproductive rights and women's health. And we would take the lead from her on different matters, but we didn't explore it as a commission up until COVID hit and it forced every one of us to kind of sit down. But we thought and we made a conscious effort that we needed to push the administration to explore race as a public health concern. And that, understanding that race and ethnicity is a predictor of life expectancy and outcome. And although we know that race, is a social construct and it was created generations ago before any of us on the phone here were born or probably thought of as a system of classification and hierarchy in our society, it has been used as a tool to kind of institutionalize discrimination since the formation of modern America. So, we, over the years, we can talk about housing and redlining. We can talk about, people not having true banking systems or people, separate but not equal when it came to education, separate but not equal when it came to the delivery of medicine, being discriminated against when it comes to employment, or because of your race or ethnicity, only offered a certain wage or a certain job classification. And when we're talking about criminal justice reform, we can go back, we don't even have to go back that far on the crimes, race being a crime, if you were in a whites only section, or when we're looking at the 80s, the difference between sentencing if you were caught with crack cocaine versus powder cocaine. So those different things have institutionalized some discrimination here in America. So next slide. And I don't have to tell you guys, we have predictors and determinants of a person that we consider in good health. And that's normally someone that has stable housing, they have clean air to breathe, they have a good balanced diet, meaning they have access to food sources, they have insurance, they have access to medical facilities, treatment and coverage, And what we saw here, we've known that, there have been disparities attributed to poverty, attributed to race, attributed to housing in America, but COVID and really in the Commonwealth has just kind of shown, blown those disparities up. And over time, what America has done is we've tried to right some of our wrongs by building in safety nets, and some of the institutional discrimination that's happened over the years. So, we have free public education. We try to tackle childhood hunger by offering free breakfast and lunch programs in schools, free medical screenings in schools. But because COVID had forced everyone to sit down and stay home and shut down a lot of our safety nets, it exposed that we still have a society of the have and have nots. So yes, we're saying that you are eligible living in the Commonwealth for free education, but when you're told to sit home and everything is digital or virtual, then we find out that people don't have access to a tablet, a laptop. They don't have access to high-speed internet, and that's both in rural and urban areas. Again, we try to tackle as a society, childhood hunger by offering free lunch and breakfast. In our minds, thinking that at least we know that children are getting 2 nutritional meals a day. But again, if we have sent children home, then school districts had to pivot. How do we still provide that service by keeping everyone safe, but making sure and ensuring that our children are being fed? And then when we talk about access to quality health care and treatment, again, with COVID, we're telling everyone, stay home, get tested, go to your doctor, call your doctor. And then we found that, okay, the location of our facilities are not necessarily ideal or accessible. The location of our hospitals, pharmacy, again, telemedicine. If people don't have access to a smartphone or to internet coverage, then they can't converse with their doctors can't see them. And when we started our testing, most of the testing was drive up. So if you are someone that doesn't have access to a vehicle, then you were kind of barred at one point in time. Now we're a little better. I'm not going to give us 100%. We're a little better, but we still have avenues and barriers to that. And then with insurance coverage and implicit bias in medicine, and people being turned away because they didn't in the beginning fit a certain profile, or their pain or symptoms were being chalked up to pre-existing conditions, or not having access to pain medicine. So that's kind of where we are with our conversations at the commission. Just exploring all of those things. And like I said, we are after looking at some of the issues with poverty, some of the issues with race, some of the issues with the other things that we were exploring, we came to the conclusion that race is truly a predictor and can be used as a social determinant of health. So next slide. So the purpose for me, again, really coming today, I'm not a medical professional. Again, I am, just an executive director of a commission of passionate volunteers. But I really wanted to leave here with us taking the time to actively identify, understand, and engage how race is a major factor in the quality of someone's life. And I think we've known this. There's been studies in different pockets when we're looking at maternal mortality, when we're maternal mortality, when we look at, even you guys have been exploring with cancer and different things. We know that there have been some issues, but I really want us to be, have an active conversation on that. And my last slide. So this is my last quote, just to leave you with you guys today, and then hopefully we can just have a conversation on either how the commission can assist or if there's things that I need to take back to the commission. But I just wanted to leave you with the quote: critiquing racism is not activism. Changing minds is not activism. Activism produces power and policy change, not just mental change. And I leave that charge to you guys because you are in a position to really produce power and policy change as we're talking about healthcare disparities and in regards to cancer treatment and cancer outcomes. So thank you. Thank you for having me. And I can stick around for some question and answer.
So thank you. And just, for folks who may want to come off of mute for some questions, and thank you, Jalila. That was really, really very informative, and I'm looking forward to the discussion. For those folks, please, you can unmute yourself, or if you called in, you may need to, if you're not able to unmute, you may need to press *6. So I'll just, kind of do that all out. And yes.
It's Suzanne Golling. Sorry, I forgot to unmute. From Pitt Public Health. I'm a member of the CAB, and I have a couple points I'd love to make to Jalila. One is it's a finite request. Do you have access to the governor's office? Because the governor's office has not appointed people to the CAB for a couple of years. And we have recommended, or the health department has recommended several minority members, and their applications for membership on the CAB have not been acted upon by the governor's office. So if your commission could deal with that, we would appreciate it. Number two, and most importantly, we really would appreciate your input and liaison in the project that Aurelia Dominic mentioned earlier, which I hope you heard about.
Yes.
And in helping us and educating us in how to best connect with the minority community to make sure that, especially during COVID, people are getting their mammography screenings and prostate cancer screenings and their doctor's appointments in spite of the pandemic. Thank you.
Yes, and I'll just briefly respond. So I am housed in the governor's office. So I have, and I do, because I'm a commission, I do work closely with the gentleman that handles the boards and commissions with the governor's office. So I don't know, whoever can get me those names, I would be happy to give a little nudge from my perspective on those vacancies. And for your second point, yes, I would love, that is one of the functions I do with a lot of agencies, is I try to give my best gut pump reaction if we're hitting the target. Because one of the things I tell people is that we need to be intentional in our message, and we have to make sure that we have the right messenger. So sometimes our messages get lost, and even with COVID, I've been pushing our communications team to kind of stretch a bit, because it's not that people don't understand the seriousness of COVID. It's just that we are not delivering the right messenger, or the right images where people can see themselves in what we're trying to convey. And sometimes we have to be more intentional and not as passive on that.
Hi, Jalila. Hi, Jalila. This is Sharnita Ziegler-Johnson.
Hi.
I loved your presentation. Thank you so much, and for all the work you do for the state. I really appreciate all the points that you made. I'm also an African-American woman born and raised in Philadelphia, so I know the area very well. I was thinking too about the last comment, the last quote you put up, and about the power structures that really do affect every part of our lives. And I don't know, we've gotten really good at putting Band-Aids on what we see as problems. And it's really hard to get underneath that. And there's been how many centuries of people being disadvantaged in our community. It's really hard to fix those things. So I think if we can stop just putting band-aids on and go just a little bit deeper, we'll get a little farther. And I'm also always thinking about how people prioritize their health. And it's hard to do that when you not only have the barriers that you mentioned and mistrust of the health community, but also they have other priorities in life. Just we go so often into survival mode in the African American community, just trying to make it day by day, and some a little more disadvantaged than others. But that also makes it very difficult. When you're in survival mode, you're not thinking about necessarily, I need to go to the doctor today. You're trying to keep the house, you know, yourself in a house, your family in a home, your children educated, everybody fed, everybody clothed, your job, and, you know, and dealing with all the other pressures that come your way. So does the commission think a little bit about, I'm sure you do, about how we can get people to prioritize their health when they're also dealing with these other things that are just about making it through life?
Yeah. So, and you mentioned it. I think the problem with healthcare, you know, aside the barrier from just insurance coverage, and I would say just the mistrust of the medical community, and people also rely on their first experience or exposure. So if a child's first experience at a doctor's office, or you know, someone's first experience going to a clinic was not positive, I think we've lost them. And again, like you said, we've been doing this for generations where we just have not receive the best quality of care. Our facilities don't look as nice, and I'm even talking about government-run facilities, so county medical assistance offices. You know, so you lose people, and then they don't come back into our fold until something is seriously wrong, because again, the mistrust, and then you know, the Tuskegee experiment and sterilization and things are, we talk about it as if it was in the past, but there are people who are still living that wasn't so far ago. That wasn't 100 years ago. People can still vividly remember or can trace relatives that have gone through that. You have the Henrietta Lacks story that's just become wide known. So I think that is probably the biggest thing we have to deal with, is just the mistrust with medicine. Even in Philadelphia, you know, people won't go to certain hospitals. They don't care how sick they are. It's just like, don't take me to that hospital, because their experience is everyone that goes to that hospital has, you know, has died or has gotten worse. So I don't know. I don't know how we overcome that. But I really think it's us getting the right messengers, and getting those trusted folks. Like I've been pleased to see that we have a group of Black doctors, and I'm going back to COVID, that kind of stepped up and have been the face of telling the Black community to take this seriously. Because I think when they popped up on the scene, you saw more Black and brown bodies getting tested. You started seeing more Black and brown bodies wearing masks. And up until that point, because of the national rhetoric and some of the things that were seen on the news, people felt, and people actually called me saying, well, we can't get it. I'm like, that's a lie. You know, that's a lie. So I think, again, it's finding those right messengers. And it's going to take some time. And I agree with you. There's so many more pressing issues that lead to our stress and just day-to-day survival, that healthcare is just not one of them, unfortunately, and preventative care. So I also we also advocate for more schools to be centers, community-based schools, where they can go to a school and have it as a one-stop shop. So the school, it becomes the community center, it becomes that linchpin, because that is a trusted institution that people feel comfortable with. I see in the chat, so someone asked, do we have a plan on how to address the Black community and convince them to take the vaccine? That is going to be a big lift. We have reviewed, the commission right now is actually reviewing the Department of Health's proposed or interim vaccine plan. Our goal is to help the Department of Health find the right partners in the community, the right medical professionals, the right celebrities, the right community activists, to get them on board, educate them on the vaccine, educate them on the benefits of taking the vaccine, and trying to build that trust. I think it's going to be a long haul. We still have people, and this is society in general, that don't accept the flu vaccine or don't accept the basic childhood vaccines. And now you're telling them that, hey, this is something that's been fast tracked, over a couple months under an administration that they don't trust, and trying to tell them that, you need to take this needle in the arm. So I think it's gonna be a heavy lift for all of us. But again, yes, our commissioner is on board to work with the health department and build that stakeholder base, because I think what it's going to take is going to be word of mouth from all of us. And okay, so someone said, does Department of Health have a communications plan with messaging as a template for us to follow? So a lot of the messaging is a number of agencies that have a hand in what the messaging that comes out from the state. So Department of Health does a lot of the technical legwork. Then you have DCED's department does a lot of the branding and kind of our slogan building. And the commissions, what we do is work with all of those entities and making sure that the messages are plugged into the right newspapers, plugged into the right radio stations, that they're buying commercial time on the right, that's kind of the sausage. Like, are they buying, if you're trying to reach a Black male, then we need to run a commercial on ESPN during SportsCenter at 10 o'clock. If you are trying to reach, older people, then we need to buy airtime on talk radio. One of the Black talk radios in the Philadelphia area is Werth. If we're trying to meet people in Pittsburgh, then we need to make sure that we're buying advertisement in Soul Pit magazine. So that's the kind of, we do have a template of kind of minority media or minority targeted media that we use. But they take every message, kind of the development of it is based on whatever we're trying to convey, but there is a template on where we post certain images, so what papers and different things that we buy. And that fluctuates too, based on, the analytics that the House has. Yes. Shared that the Office of Health Equity is working to support and facilitate the vaccine update. So yes, it is. There's a lot of people that have a lot of hands on all of this. So you have, of course, all the different divisions in the Department of Health. You have the commissions. You have just like the governor's communications team. There's different task force. So there's a lot of pots working on different angles, but the goal is, again, to make sure that people are aware that this is going to be safe, and that, we're prioritizing their health.
Are there any other questions on this presentation? All right, it doesn't look like there are any questions. Thank you so much, Dalila. That was a wonderful presentation and discussion. We're very happy you could join us today.
And I'll add my contact information to the chat so people can have it going forward. Thank you guys for having me today.
Thank you. All right, so I believe our next slide, I think we are up for a break. So we will take a 15-minute break. We're right on schedule. My clock tells me it's 10:15. So we will take a 15-minute break and reconvene at 10:30. Thank you very much.
Thank you.
All right, I have it as 10:30. Kate, are you back on and ready to go?
I am.
All right, then we can go ahead and move to our next slide. All right, so next I'm going to introduce our outgoing co-chair from the DAC, Nathan Werth. He is going to provide tips on how to get data and what to use when. And this presentation's a result from comments we had received in the PCC annual satisfaction survey, and there was interest from participants for additional detailed instructions on how to access data. So Nathan, I'm going to go ahead and turn it over to you.
All right, thank you. Can you hear me?
Yes.
Awesome. Okay, so good morning, everyone. And as she mentioned, that this is by popular demand. We're going to go through and give a intro to the cancer data the Department of Health puts out there. So first, I'm going to start with some basics of what you need to know to even get context for the data. Then we'll work through a hypothetical question and look at use the online tools we have to kind of explore that. And then finally, we'll end with how to request your own custom data. So next slide. So the first thing you need to understand, almost all of our data is based on counts of cancers, not counts of patients. If you check our reports for 2017, there were 77,824 invasive cancer diagnoses. That is not the number of patients who were diagnosed with cancer in 2017. This is just how cancer data is. We count the tumors, not the people. Of course, every single rule has an exception. In this case, the exceptions are prevalence data and net survival. Those are specifically about what happens to the patients. Prevalence is number of patients, so of course it's a count of patients. And net survival is how long they survive after diagnosis, so we're still looking at just the patients. So those two are counts of patients. The second thing to understand, we pretty much just look at invasive neoplasms. So these are malignant cancers that are starting to spread out from where they first appeared. These are the ones that are really dangerous, so this is what we focus on. The exception to this rule is stage data. We do early, late, unknown stage. Early includes in situ. In situ just means in place. They haven't moved from where they first appeared. Next slide, please. So currently what we're putting out right now, we have some historic reports on our website, but the ones that we keep putting out right now are the net cancer survival in Pennsylvania. This is going to be the upcoming edition that's going to come out soon, hopefully, is going to be the last one. They're not very popular. We're looking at replacing them with something else that'll get the same effect that we wanted. What we wanted was net cancer survival is difficult to understand and to use. So we wanted to give it a more of a context where we go into what this could mean, what could be affecting it. You know, this is epidemiological population health study. We can't say what does what, but we can say that this is where people are suffering more, and we can point this thing out. And because net survival is hard, we wanted to do that in a report and really focus people. But it's not getting read, so we'll figure out a different way to do that. The cancer standard output tables, they are just giant tables of counts. No narrative, just lots and lots of counts. They were the go-to for most researchers who needed counts, and a lot of people who got used to them still use them, so we still make them. Pennsylvania cancer incidence and mortality is pretty much what you would hand to a legislator. You'd print out one chapter, like the colorectal cancer chapter, and you'd hand it to a legislator and say, hey, that's what you need to know. It's pretty good summaries. We've been moving more to interactive tools for our reports. So the big one that we're really pushing is the cancer statistics dashboard. And I'll get into that later. We'll work through that with the hypothetical, but it is a really interactive way to explore our data through graphics, through tables, different kinds of ways to look at things. It's really cool. Eddie is our somewhat older, it was 2016 it came out, way to explore the data. It's really, really good if you're going to do analysis yourself. If you want to get the data, put it in Excel, put it in SAS, whatever you do, I would suggest going to Eddy. It's really good to just query what you need, print out a huge table, save it, use it on your own. Next slide, please. So common questions we get about cancer data. Why is it lagged by 2 years? For example, in January of 2020, we published diagnoses from 2017. So January 2020 only covered data up to the end of 2017. So why does it take so long to get this data out? First, by just the laws, facilities have a year to get the reports in and let us know about the cancer diagnoses. So that's one of those 2 years already. And that's not even considering the fact that not all facilities are very good at getting this stuff in. And it's biased against certain cancers. So prostate cancers are notorious for having more late reports than other kinds of cancers. So it's hard to use earlier, like an earlier cutoff. We're trying, and we're looking at ways with national registry associations, but we're still getting there. We then match these records to other sources, death certificates, bunch of other sources, but we try and get the best data we can, and those have good data that we can use. The reports from hospitals and facilities don't always have everything. They may not track that patient. So we're trying to hit as many points as possible to see what's the most recent information for that patient. Is he still alive? Do we still have an address for him where he lives now? So it takes time to get these data sources. Some of them are lagged, and it's a lot of quality control, which is the last point. There are thousands and thousands of records. Like I said, over 77,000 in just invasive cancers for 2017. There were over 80,000 of all cancers, and we get multiple records per cancer. They have to combine them. They have to see if it's the same cancer. They have to determine that is a different one. It all takes a lot of time, and I'm actually always amazed that the registry can do all it does in the time it takes. Next slide, please. So another common question, one that of course people would ask, how do you define or how do you calculate such and such, age-adjusted rates, net survival, things like this? So all our reports have technical notes. And in report, that's easy. Look at the back or in the front, it's got technical notes. You can read those. The dashboard, at the top of the dashboard page, it has a link to the technical notes, and we'll see that later when we go look at the dashboard. In Eddy, the technical notes are a little harder to find. I think they tried to make them easy to find, and it did the exact opposite. So in Eddy, there's the little windows at the top of the screen where you can select what kind of cancer you want, what age group, all that. If you click the title bar, and if you see on the slide, the little red box around the blue title bar, if you click that, that'll open another little window, which gives good technical notes for what that selection actually means. And we also, on our website, we have a tools of the trade page. It's under understanding health stats. That page has different PDFs and just descriptions of what's an age-adjusted rate. And then we walk through a very good description of it, and it has some example data. It's really good. And if you can't find something there, use Wikipedia. I always use Wikipedia for this stuff. It's actually very good for this. Next slide. So we're going to start with a hypothetical, because it's the best way to show off what you can do is by actually just doing it. So in our hypothetical, we're going to look at this national trend. So colorectal cancer rates, the incidence rates have been going down over the years, which is great. However, among younger people, especially those below the age where you're recommended to go get, regular colorectal cancer screenings, the incidence rate has been increasing for those younger people. So our hypothetical is, among young Pennsylvanians, well, first off, is this a thing in Pennsylvania also? And if it is, which demographics or geographic regions have the steepest increases? Which ones are hurt most? Now, I'm going to try and share my screen, and if this doesn't work, we'll figure out something else. Is there a way I can share what's on my screen?
So Nathan, I am going, oh, sorry for the echo. Let's see here. So at the very top, Nathan, if you can see, there might be some request of control.
Okay.
Are you
So
able to grab that?
Yeah.
Okay, so the floor is yours.
Are you able to see the website?
No.
Okay, that's fine.
What you can do, if at the top of Teams, right next to the microphone, there's a little box with an arrow that says share content.
I'm not seeing this, so we'll go with the backup.
Okay.
It'll take more time. So I'll give back control. Oh.
That's okay. We'll just give 1 second here.
Sorry about that.
No worries. All right, so we'll just quickly go through these. Bear with us. We'll be right back. So Nathan, I think this is the slide that you had us on. Okay.
So next slide, please. So the way you get to the data, and this is what I would have done if I were able to share, and I'm sure there's a way I could have, I just don't know it. Health.pa.gov. If you go there, that'll take you to the Department of Health's website. And then along the top, right above the giant image banner, there's the little menus you would say, I'm looking for, and then health statistics, and that'll take you to our website. Next slide. On our website, below the giant image banner, there is all the different types of statistics we give with the little icons. So you can see we have the behavioral statistics, the birth and death, and then there's cancer. If you're looking at this on a phone, there is no giant image banner. This should just be at the top. And also on that same page, below those icons, it's not shown here, but below those icons is a nice little list of what's been updated, what's new in reverse chronological order. You can see like what, if anything's changed on our website. Just check in there every so often to see what we put out. Next slide, please. So if you had gone to that cancer page, and then you would see a listing of our reports. Cancer dashboard is the first thing listed. You click there, you click the icon, you get to the dashboard. The first page of the dashboard is a whole lot of numbers on a whole lot of things. And it might be a little intimidating at first, but once you get used to these numbers and once you get more comfortable with reading them, it is a great way to just look at individual cancer sites and see what's going on. Is it going up? Is it going down? What about mortality? How many people have it? All this stuff. It's a great way to just get a quick sense of it and know what to look for next. The way you go page to page in the dashboard, at the bottom where it says page 1 of 14, it's kind of small there, but it's circled in red. If you click that, that'll give you a listing of all the pages, and then you can just scroll up and down, pick which one you want. So again, going back to our hypothetical, we want to know, well, what about the trends among young people versus old people with colorectal cancer? So we're going to the trend summary page. Next slide, please. So on the left of these pages, and this is true for pretty much all pages in the dashboard, are the little tools you can make selections and filter down the data you want. So in this case, the trend summary, we're going to look at the trend range. We're going to change that from a very short-term recent trend to 2017, because we want to look at the long-term trend. That's what the hypothetical was over the long term, there's this divergence. So we changed that. Below that age group, let's start with the older people. So 50 to 64. So we change that to 50 to 64, and then the graph is going to rearrange itself, get new data, and you can see at the bottom, colon and rectum, the average annual percent change is negative 1.6%. So on average, every year, that rate has been going down 1.6% for people aged 50 to 64 in Pennsylvania. So that is going down. All right. If we click that bar, you'll see it highlights that bar and kind of tones down the others. Now it's selected. Now it's going to keep focus. So when we look at the other age group, it'll stay in focus. Next slide, please. So if we go back to that little age selection tool and we change that to less than 50, new data, new chart, colon and rectum still focused. So we can see that it jumped way up that list, and now it's actually increasing 1.8% every year. So yeah, this trend exists in Pennsylvania. Over 50, trends going down. Under 50, trends going up. Next slide, please. So now we've established it is true. Which groups are most affected? First thing I'm going to look at is the age group. Well, here I'm going to kind of see, I'm sorry, we're not going to look yet about which is most affected. We're going to get some context for this. So let's go to the trends page. And again, you go to the bottom, click the numbers, choose trends. And this lets you compare between different groups. So it's great for a comparison. First, let's do some sanity checks and just compare by age group. So on the left, along the top, I didn't circle this, but along the top, you select age for compare by. On the left, you select colorectal cancer. For trend type, we're going to keep it on modeled. And for rate type, we're going to switch to delay adjusted. On the next slide, I'll explain what these mean, but this is the choice we're going to go with. Then we get the chart we see on the right. So the trend is going down for the much older population, and it is going up for the younger one who's at the very bottom, the little dark line. What this tells us is that even though the rate is going up for the younger group, it is dwarfed in number by the older groups. So it's not a apocalyptic scenario. It's bad, but it's not apocalyptic, and this is why overall colorectal has been going down and why it's almost been hiding this. If we go into the age selection things, we could also deselect the 65 plus and just look at 50 to 64, the group you really want to target to get them in for screening right then, like to introduce that screening. And you'll see that the younger rate is still running along the bottom, even though the older rate now takes up most of the graph. Next slide, please. So going back to why I made those selections with modeled and then delay adjusted. I'm just going to sum up this slide as use the right tool for the job. After the meeting, when you get these slides, feel free to print this one out and post it up and keep it as a little handy thing. Add your own notes, whatever. But we put out a lot of different statistics because it really depends on what you want for which statistic you use. So I chose to keep the modeled rates because I don't care about exact data for each year. I care about the overall trend. The model shows that overall trend. I also use delay adjusted. Like I said before, some reports come in much later than they should. Years later, 5 years later, 7 years later. And we can adjust for this. We can say, well, in the past, we had this many delays. So we can guess that once we get everything, this is what the number would be. So we're going to show the trend for what it probably actually is instead of just a recent dip just because people haven't been good about reporting. So it accounts for like a false dip, which is nice, but may not be the truth. And of course, we're looking at trends, so that's historic. Later in the dashboard, you can also look projected data. Because projections are hard to do and they require a lot of data, we don't have them for every little breakdown. So we can't get projections by age group. We don't do that. It's very limited. But it's really useful to see, well, this one's been rising. This cancer has been rising. Thyroid cancer has been rising. What's it going to be in so many years? Actually, I don't think thyroid cancer is rising that much anymore. Next slide, please. So going back to the trend summary, now let's compare and find groups that are really suffering from this. So we'll start with sex. Along the top, you click sex to compare by sex. Now we get two new lines, one male, one female. And as is usual for a lot of cancers, the male rate, much higher than the female rate, but both have been increasing. But these are kind of almost increasing at the same rate, so it's hard to tell what actually is the difference. Is it the same? Is it very different? So along the bottom, you can see that there's a table with these numbers, but it's tiny and it doesn't actually show all what we want right now. So next slide. If you notice above all the tables and all the charts, in the top right, there's two little tools. One looks like the funnel, and that's to filter down. And we have the filtering tools on the left, so that funnel doesn't do much. Next to it is the expand screen button. And if you click that, the table will now take up your entire screen, and it will fill out as much as it can on your screen. So now we can see this whole table, and we can see that the female average annual percent change has been higher than the male. So even though they have the lower rate, theirs is climbing up a little more. Whether that's statistically significant, that test wasn't done and it's not seen here. So I'm reminding the dashboard, really great for exploration, but if you want to do your own analysis and make your own statements, unless it's stated in the dashboard, you're going to have to do your own analysis. And later we'll go to Eddie and I'll show you how to get data out of Eddie to do this. Next slide, please. So after minimizing that, the next kind of question people have, can I save this graph? You know, this is a nice graph. It's really clear. So you want to use it in a report. Unluckily, the dashboard does not have a button to just save a graph. So you can use a snip and sketch or a snippet tool. That's what it's called on Windows. I'm not sure what it's called on Macs or other operating systems. You could also use the print screen. So on your keyboard, there's a button that will say like PRNT or PRT-SC, that's print screen. And then you open it up like a paint or drawing program, and you just paste into that from the clipboard, and you got your screen. Then you just cut out what you want. So it's not impossible, it's not easy, but you can use these. Next slide. So now's the point in any kind of analysis where I really start doubting myself. Is this trend bad? Like, it is possible that the increase in colorectal cancers among young people is because they're just better about screening now. So we're front loading all these colorectal cancers. It's a bunch of really earlier ones that would have been caught later when they're older. So now we're seeing more young, less old, which is something that could be good. But I don't know. So along the bottom, I click the numbers again. I go to the stage distribution page. I'm going to compare by year, and along the top, that's where you can select what you compare by. And then for these selections, change to colon and rectum again if necessary. That doesn't always keep between pages, so make sure you have the right cancer selected. In year, I just go through and I select them all. There's a little button you just say select and it just shows all the years. And then for age, I'm going to restrict it to the 35 to 44 years. Not all the age groups are the same across the different dashboard pages. Again, this is for exploration, not the final analysis. So this is great for seeing if you're right about things or being led to know what to really look into. But so I'll pick a good age group. I'm going to say 35, 44. You know, risk of cancer goes up as you get older, and this is the age group that's below 50. Doesn't overlap, but it's the oldest below 50. So then we get the bar charts on the right, and that is really hard to read. And that's just how it is. It's hard to read, not just because of the colors, but also because the data goes up and down a lot. I would say it's way too muddy to make any kind of predictions from it, especially because as you get younger, you get less data for cancer. So the less data behind the rates, the less I trust it. The more I need to actually look at it myself and make sure that it's legit. So again, later, we'll make a note. In Eddie, we'll download this data so we can examine it in Excel or whatever you want. Next slide, please. So before we leave the dashboard, let's see if there's any regional differences. So if you go to the map page, you can see each county's incidence rate for the most recent 5 years. Now you can change that. You can look at different kinds of cancer. You can look at mortality. You can look at prevalence. You can look at net survival by county. You can change the year. This also allows you to look at projections. We make projections by county, so you can see, well, this county doesn't have many counts this year, but what's it going to have later? So here we're going to change to colon rectum, and we're going to change the age group again, 35 to 44. And now here's the thing where I said we did not have enough cases. Because it's a young age group, cancer is less common, and if there's less than 20 cases in a county, we don't show an age-adjusted rate for it. You can make it yourself. Later on, we'll get the data. You can make it yourself, but we don't put it out there because we're not going to put our names on something that is totally unreliable. So sadly, we can't see really if there's any geographic differences. None jump out to me, and here it's basically just the Pittsburgh metro, the Philadelphia metro, and Scranton metro, I'm betting. So that was a dead end. Well, let's go to Eddie. Next slide. So the way you get to Eddie is back on the health stats homepage. Along those little icons, you can click the Eddie one, the health stats query system, and that'll take you to a page, and then you click again to get to Eddie. Next slide. Yep, that's the link you need to click. So yeah, when you click the first thing, it doesn't take you directly there. Below the title is Enterprise Data Dissemination Informatics Exchange. That's the long name. If you click that, you'll actually get to Eddie. Next slide, please. So it'll take you to a page where you can choose which data set you want. There's a lot of data sets on Eddie. There's ones about all kinds of deaths, when housing was built, so that will tell you whether or not it probably has lead paint, childhood lead poisoning, STDs. But right now we're going to stick to cancer incidents, and then you can select geography. There's municipality data. We just give counts for that. We don't make rates because, again, low counts. So, but right now we're going to keep it at county and state. And then because it's nicer for exploration, we'll do the chart. You can also do tables, which just gives you a table. But if you do a chart, a table prints out below it. It just really restricts what you can select because it's whatever can be charted. Next slide. So once we hit the submit button, we get taken to this page. Bunch of selection tools. It kind of looks like the dashboard, except all the selections are expanded. On the left, for primary site, we'll pick colon and rectum. We'll keep it on Pennsylvania. For the years, we're going to look from 2001, 2017. The trend, we're going to change the chart type to a trend line because we're trying to recreate that trend of early stage. That was a little muddy in the dashboard. We want to see a nicer line and then get the data and then examine it ourselves. For the age group, Eddie has more consistent age groups and a lot more choices. So it has individual 5-year age groups. It also has age groups broken by screening recommendations. We have ones for below 40, above 40, below 50, above 50. It's made so that it's really easy to just pull out the numbers used in reports. So we'll change age to less than 50. Stage, early stage, which is in situ, localized, it's still within the original organ, still in the colon and rectum. And then when we got everything selected, we press create chart. Next slide. So now we can see the trend line, and it goes up and down, but we can see it doesn't really have that as much of a trend. Because it goes up and down so much, it's probably going to go up again, back down again. No real way to know where it's going. If you hover your mouse over individual data points, you'll see the rate for that year along with the confidence interval. Along the bottom, if you see like circled, it says Pennsylvania is yellow. This is because we could have compared different counties. In the chart, we can only compare counties. You can't compare between different stage groups. The chart's kind of limited that way. If you want to do that, you'll have to get the data yourself and look and do it in Excel. To get the data, to the top left of these charts is the little diskette icon. So if you click that, it'll give you different options. You can save it as a picture. You can save it as a Word document. You can save it as a PDF, but we're going to choose an Excel file. Next slide. So once you click that diskette, you'll see all those options. We pick Excel. It's gonna save itself, and we'll open it up in Excel. And here you see that it has the image, and below that is a table in Excel with all the rows and everything. So you keep the chart and you get the data. So then you can analyze it however you want. If you had gone back to Eddie and instead of choosing the chart tool, you chose the table tool, you could have made any combination of things you want. And Eddie can put out like tables with 1 million rows. I've actually really pushed that to see what the limit was. I think once you hit 25,000, it slows down a lot. But you can get like 25,000 rows in that with all the selections you make. It's really good for just grabbing chunks of data to analyze yourself. Next slide. So if we don't give data that you want, you can request it from us. It can be any data source that we keep. The only one that is really off limits is abortion data. That has a lot of protections around it. Well, they all have a lot of protections around it. That's even more. Everything else you can request. So you can request cancer incidence, aggregate numbers, BRFSS measurements for what percentage of people were smoking in that year, things like that. We only provide the counts. If you want individual data, you can request it from the registry who keeps it. That's their own system and that's their own process, and that's a lot stricter. We don't ask that you keep things confidential because we won't give you anything that is confidential. And it will take some time. So we have other work we do, but we do love to help people, but expect about 2 weeks between when you make the request and when you receive the data. And that, you know, if you're responsive to our emails, 2 weeks is, you can probably get less than that. If you take a while to respond, it will take a while to get back to you. Next slide. So why would you request custom data? There are specific types of cancers that we don't report. We try to report as much as could be useful, but there are lots and lots of types of cancers. So we stick mostly to the main 23 sites that sum up a lot of the ones that are the big problems today. But if you want to look at a very specific childhood cancer that's caused by a very specific cause, and you want to see, well, does this county have a higher incidence of that because it has more waste sites? Well, you're going to have to make a custom request, probably, but we can do that for you. As long as you specify, this is what I want, we'll get it for you. We do more specific races than just white, black, Hispanic, Asian, other. The registry collects a lot of race data. Mostly Asian races are really categorized because they cover a lot of the world. So what's counted as Asian covers a lot of the world. So you could ask for Korean cancer incidence. Again, if there's very low numbers and very low populations, we might not put it out there because it might be able to point to individuals, and we don't want that. But as long as you get a big enough area, we could probably get you that kind of thing. So if you want to look at specific cultures and which ones are more impacted, you could ask for that. The number one reason people ask for custom requests is they have a different geographic area. And a lot of times it's because they have a different data source and they have to match to that. So they might have zip code data for house information. You know, does it have lead paint? Does this have poverty in there? So they need zip code data for cancer. We don't usually do zip code data. That's the postal system. It's not actually a great system for nice and consistent and good neighborhoods, like well-defined neighborhoods that make sense. But if that's the data you have, that's the data you need. We can do legislative districts. We can do census tracts. We can do very fine-grained, very different ways to combine things. Whatever you need, make a custom request and we can do it for you. Next slide. So what data do we have? By we, I mean me, with the cancer data. Our registry collects a whole lot of the items that are defined by NACER. Not all of them are required. If you want to see what NACER has as data items, there's a data dictionary online. I put a link here. You could also just Google NACER data dictionary and it'll probably take you there. NACER is that international Association of Cancer Registries. It says North American, but they've been spreading out and they have partnerships with other ones. They all work together, and this is why cancer data is so easy to combine on the national level. We don't collect everything. Some things we stopped collecting because they were just rarely reported or totally untrustworthy. So occupation and industry of the patient was not working so well when they were tired. Which occupation do they count? The one they worked in longest, the one they worked latest? And because cancer hits older people more, that problem was coming up a lot. And they don't always report it, so it was just not very useful. If a new item comes out, we can't go back and collect it for old records. Sometimes we can figure out what it would be, but a lot of times it's just blank. So if you're choosing like newer things that are collected, like new ways they stage the cancers, we don't really always have that for older records. So just keep that in mind. If you want to know specifics, you can contact Wendy Aldinger. She's the head of the Pennsylvania Cancer Register, and her email is down there. Next slide. So on the Health Stats website, there is a page for requesting data. And this will take you to an online request form. So it doesn't ask that much right here. You just got to fill out and submit this form, email address, your first name, last name, phone number, so we can contact you, and then a little text box saying, what do you want? And then we take that and we give it to whatever statistician is in charge of that data, and he's going to reach out to you and talk with you about how this is going to go. If the data you request is something we collect and that we can share, then we're going to ask you to send a letter of request. And this letter can be in any format. It could be a scanned PDF. It could be an actual physical letter, whatever. We just need something that we can point to later. And in a second, I'm going to show you what's necessary on that. The reason this form doesn't just take you to the letter of request immediately is because if we don't have that data, we will try to find it for you. We will try and point out whatever website, whoever you need to contact, we will try and get you connected. After the letter of request is in and we're okay with it, then you pay the fee once we figure out what that is, and you receive the data. And I'll go over this in a second. Next slide. So the letter of request. What's required of it is your name and organization, so we know who we're giving it to. Your contact information, so we can contact you later on if something was wrong, if we shouldn't have given you that data, or anything comes up. You need to give a detailed description of what you want. Otherwise, we're going to get it out of you anyway. It would just be a lot of emails back and forth. So here's a good example of it. Someone who wants invasive cases of mesothelioma that were diagnosed in Asheville from the years 2008 to 2017. And they want the counts tabulated by race and gender. We can do that. We can do that right away. We don't need to go back and forth and say, what do you mean by this? What do you mean by that? You got to say what you're going to do with the data. So if you're going to just analyze it for yourself, okay. If you're going to publish it, we kind of want to keep tabs on that. We'll probably look at it. We'll see what you wrote, all that. We want to know how our data is being used. You have to acknowledge that there could be a fee. So we don't have a flat fee. It depends on how long it takes. But you need to acknowledge that that fee could be there so that later on we can point that, yes, you did know that it would probably cost money. And then there's a signature at the bottom. It's a document. You got to show that you actually signed it. You actually read it. You actually wrote it. Next slide, please. So the fee. This is a point of contention. Your letter of request is not a promise to pay. It'll get us started on the work. And once we get a good idea of how long it's going to take, or if it's a really quick thing, it's already done, we'll tell you how much the fee is. You then have the option to not pay it. But if you don't pay it, you don't get your data. It's that simple. Our pricing is we charge $200 at minimum. So if we're going to charge you, it's going to be $200 at least. And then it's $50 an hour. The first 4 hours are included in that $200. So if we go 5 hours, it's $250. And we really only know the final cost until the work is done. If it's directly for the Department of Health, like if you're a program that works hand in hand with the Department of Health, please mention that, because we don't charge a fee for that. That's just doing work for the Department of Health. So a lot of the data requests that I've done for the CAB and the PCC, I have not been charging. I've not been making them go through this entire form process, because that's Department of Health work in my eyes. If you have something else, like you want to do a research paper, you're going to need to do this form and application. Next slide. If you want the individual records, and some researchers need this if they're doing very detailed analysis, you're now getting confidential data that identifies people. You got to contact the registry itself. So if you want cancer, birth, death registries, you write to this email address. It'll redirect it as necessary, and it's there. It's ra-dhprotecteddata@pa.gov. That'll get your email to wherever it needs to go, and then they'll reach out to you. And that's a process that I'm not totally familiar with, but you're going to have to prove that you're trustworthy, that you're going to use it right, all that. BRFSS records, if you want the individual respondent records, you can get that from the CDC. They just put that out there. It's lacking of some details of geography, so they group it by larger county areas, by state, but you can get the individual responses. So if you're working with BRFSS data, I would suggest going there if you want to do more detailed analysis. Next slide. So that's what I have prepared of what I think people want to know, with a little walkthrough too. But this part of the presentation, few minutes we have left, we're going to open it up to the chat. If you have any questions, ask it right now, and I'll answer as I have time. If any questions come in and we run out of time, we'll write them down and we'll get back to you all later. So if there's any questions, please put them in the chat right now. I'll wait a few seconds while people have questions. I'm hoping everyone does like the cancer dashboard. It's taken a lot of work, and we're adding more and more as time goes on. Just to let you know what's coming up. So the net cancer survival is almost done. It's almost out, in case anyone reads that. In January, we expect that EDDI will be updated along with the standard output tables. So that's where you want to go if you need the data very soon for 2018. That's going to have 2018 diagnoses. The dashboard will not be updated until probably April or May, going by previous years. It takes a while. It's got a lot of work behind it, and we're moving it so it's easier on our side to do technology-wise. We've been doing it on our laptops, and that's been a real problem for how much we're adding to this stuff. All right, well, for 2 minutes until my time's up, and not seeing much questions. Thank you for all the praise. So I'll just hand it back. If you have any questions, keep writing them in chat. You can email me. I am nwerth@pa.gov. It's here. Oh, here's one. So Monica, yes, it is possible to look at race. Like I said before, in our reports, we pretty much do poverty is a good one, but for race. So we pretty much do white, black, Asian, Hispanic, which is ethnicity. And then there's an other. We usually don't show that because it's not as useful. Personally, I don't use Asian as much because I don't trust it as well. Hispanics kind of like this too. That depends on the accurate they are, because it's patients talking to doctors or doctors making assumptions. We found that it doesn't always match up with the population numbers from the census. It's not as trustworthy. So if you're just looking at like the trend among Hispanics, you can trust that it's trend. It's going up or it's going down. But if you're comparing Hispanics to white, that's a little iffier. Yeah. And so Hispanics and Asians.
Nathan, I'm sorry. Let me clarify that I'm sorry. I pressed in too soon. I was thinking about looking at race as it relates to maybe poverty and cancer? Can you see the relationship for that? And can we tell by certain, ethnic racial groups what their poverty level is connected to the different types of cancer they might have and the mortality they might have from that?
So yes, actually we can. That's something we've been able to do for the past, like 5 years ago. The registries got together and they made a nice way to define and all agree on neighborhood poverty level. So we look at census tracts, which are very small areas of land, bunch of blocks put together, and we say, all right, what percentage of households are below the poverty threshold? And then they split them into 4 groups of very high poverty, moderate, or low poverty. So we do that. That's in the net survival report, because that report was made after those definitions were made. That does look at that. And in net survival, at least I can say that once you compare by poverty level within those poverty neighborhoods, race does not play as much of a factor for net survival. It still has an effect, but it seems like a large amount of effect on net survival is what's in your neighborhood, what resources you have access to. We don't do individual poverty. We don't collect individual patients' income, but we do neighborhood poverty. And some studies have shown that that's actually more of a determinant. So you can be above the poverty line, but if you live in a very impoverished neighborhood, you're not that much better off than your neighbors. You're all pretty much hurt. If you do a custom data request, we can give you this data. So if you need it, we can give it to you. And I should have mentioned this before. If your data request is really, really simple, sometimes we'll waive the fee because it's just paperwork on our end we don't want to deal with. So if your data request is something I can run in half an hour, I'm probably not going to charge you for it. If you make 2 in a year, I'll probably charge you for it just to keep you from doubling up. But we can look at poverty data that's available. And if enough people want it, we could see about adding it to the dashboard or future reports. And whatever I turn the net survival report into, I'm keeping that. I like that way of looking at it. All right, well, I'm 2 minutes past my time, so I'm going to bow out. And if anyone has any more questions, keep writing them in the chat or email me, and I'll send out the answers to everyone in the coming days. All right, thank you.
All right, thank you very much, Nathan. That was very informative. Lots of good comments in the chat on how many people found it useful. So we really appreciate you taking the time today to present all of that for us. So Kate, if you want to move us to our next slide. So next, we have Heather Batson from PHMC, who heads up evaluation activities for the Comp Cancer Program, looking at what the CDC calls the 3 Ps of program, plan, and partnership. Every year, Heather sends out a satisfaction survey to the PCC members to measure the partnership component. And today, Heather is going to focus on what members said about the partnership component and measures the Comprehensive Cancer Control Program along with the executive team of the PCC will undertake to address any concerns or suggestions offered. So Heather, I'll turn it over to you.
Thank you. I was actually wondering if I can have control because I have some updated slides. Is that okay?
Yes, Heather, that would be fine. If you want to, at the very top where you would be able to grab control from me.
Okay.
Do that. Okay. And so from there, if you have content to share, because I can stop sharing this slide deck if you do have then slides that you want to share. Same thing that I had walked Nathan through at the top. There should be a little box with an arrow where you would be able to share content. Do you see that box?
I do.
Okay.
Oop, this is not the right one. Hold on. Okay. Okay, can you all see my slide deck now?
Yes.
Okay, great. So yes, so as Kelly said, I'm going to be sharing some findings from the PCC member satisfaction survey and also some opportunities for continuous quality improvement that the subcommittee has suggested. So first, I just want to explain what the data sources are. So the main one, like Kate said, is going to be the annual PCC member satisfaction survey. We usually do that in April and May, but it was done a little bit later than usual due to the COVID chaos. So it was fielded in August, late August, early September. This is based on the 9 Habits of Successful Cancer Coalitions. And if you want to take a look at all of the 9 Habits results, you can take a look at the full annual report. I'm not going to go through every single one of the 9 Habits results because I kind of have 6 takeaways that I want to talk about. This also included additional benefits and challenges to PCC members, which is data I'll present today that's not in the report. There is a caveat about the member satisfaction survey, which is that we had pretty low participation, which is typical for the survey. This time there were about 37 responses. We sent it to everybody on the PCC list, which was 320 people. 10% participation is actually not terrible for an unsolicited email survey, but we would like to do better. So we're working on hopefully having higher participation next time. We also took a look at some membership data. So the membership list, attendance information, and the other things that are in the membership records. Okay. So our first finding is that participants did report some perceived improvement in certain habits, including the effective communication habit and the clear rules habit over last year, but there's still some room for growth in these areas. Okay, so let's take a look at the effective communication habit. We measure this habit with these 4 statements. The level and quality of communication with coalition members is appropriate. That we saw some improvement in over last year. PCC meetings are effective. We work on activities related to cancer plan implementation. That's been pretty stable. Leaders of work groups and subcommittees have regular communication with members, successfully facilitate group functioning, and help members feel connected to the PCC. That we saw improvement in over the past year. And PCC members communicate with their work groups and subcommittees through the year, not just limited to PCC meetings. That also saw improvement. So as you can see, these are mostly green, which means they strongly agreed or most members strongly agreed or agreed. But of course, we would like to see everyone strongly agree or agree with this. There are still some folks that are neutral or disagreeing. So that's an area for growth. So we've also seen some improvements in the perception of role clarity since last year, but again, there's still areas for growth. These are our 4 statements, and we have seen improvements in all of them. I want to spotlight a little bit the roles and responsibilities of PCC members are clearly understood. So we still, although a majority of people strongly agreed or agreed that these are clearly understood, we have a little more than 40% who answered the survey that were neutral or disagreed with this. And new members of the PCC are oriented to their roles. So just under half strongly agreed or agreed to this, which means that percent were neutral or disagreed to this. This is an improvement over past years, but new member orientation, which is always a challenge for coalitions. It's not like there's something wrong with the PCC. It's just that it's always a challenge. This is still something that we have an opportunity to work on and improve. So this kind of summarizes these takeaways. Overall satisfaction with communication still has a little room for improvement. Most responses suggested that the work groups are communicating well with involved members, but maybe these could still be used to help members feel a little bit more connected to the PCC overall. The roles and responsibilities are still not clear to about 2 in 5 members. So we can consider some ways to make roles more clear. Possibly related to this lack of role clarity is that there's definitely a clear need to continue to improve onboarding of new or prospective members, ensuring that they're oriented to what their role is and that they find their right space on a work group or subcommittee that fits their interests and skills. And related to this, we suggested that we should consider developing some mentoring opportunities for new or newly energized PCC members within the work groups and subcommittees. So finding number 2 is that participants in the survey perceived some areas where the PCC would benefit from more representation from some community members. So although more than half did say that the membership of the PCC is diverse and represents all sectors of the community, about 45% were neutral or disagreed with this. And even some of those who agreed that the membership is diverse and represents all sectors of the community had some suggestions for parts of the community that could be better represented that we had a write-in. So these are mostly quoted the way that the people put them in. So racial and ethnic minorities was one spotlighted group. There were several mentions using similar language. Low-income community members, LGBTQ, survivors also had several mentions. Caregivers had several mentions. Legislators, payers, community groups of all types, and representatives from state agencies, and particularly CHIP, WIC, and BCHS were called out there. So we were able to take a look and see at who among the survey respondents was a survivor or close friend or family member. So about 2/3 were personally affected by cancer outside of their work. So they were a survivor and or a close friend or family member, with 3% being survivor and family member, 5% a survivor, and 57% close friend or family member. And one thing that was really interesting is that many of the people who suggested that we needed more survivors were people who reported being a survivor or a close friend or family member, but who seem to have some other role in the coalition. So it may be that even though they have that personal experience, they know that they're not really able to be an advocate or work in survivorship because they have something else that they need to do. And they would like to see more survivors and family members included in there. We are able to look at what organizations PCC members are from, and they do represent a very wide variety of organizations. However, membership doesn't include information like demographic characteristics, so we can't track how well the PCC is doing with inclusion on these dimensions, so we weren't able to test the perception against the reality of the membership. So we might want to consider including more information in the membership roles. And the evaluation subcommittee doesn't doubt that that perception is accurate, but we did want to take a look and see like what could we say about this, but we can't really say anything. We did find that the PCC does in fact lack representation from legislators, payers, and the specific state agencies mentioned by respondents. Participation in the PCC and closer relationships, if not possible, would probably be beneficial to PCC interests and Pennsylvania residents overall. Some survivors and members from underrepresented groups may experience role conflict, bringing personal experiences to the table if they're involved with the PCC in a specific professional role. So we do suggest that we make sure that we have people whose entire role in the PCC is to represent that voice. So the takeaways are that we think the PCC should recruit more cancer survivors and family members to participate in survivor caregiver roles, especially for the survivorship work group. The PCC should recruit more members from underrepresented communities and communities with a disproportionate cancer burden, including LGBTQ populations, low-income people, and especially Black and African American Pennsylvanians. And as we've heard, this is something that is ongoing and that we're thinking about. It's not like this is coming out of the blue, but these are findings that we're seeing. And to be most effective, these new members really need to be provided with a clear orientation to their roles, including mentoring as appropriate. And the PCC should also forge more ties with legislators, payers, and additional state agencies if possible, or recruit representatives to the PCC if that's possible. Our third finding is that meeting attendance increased substantially in the 2019 to 2020 year compared to previous years. And we think that this is possibly linked to greater virtual access. So this graph shows September, December, and June, because there weren't any March meetings in the 2019 and 2020 or 2018 and 2019 year. So this green bar here is September of 2019, not September of 2020, because everything in this report is before July of 2020. But you can see that this like bright green bar in every year is much bigger than the previous years, even though in December of 2019 we were already seeing, in 2018 we were already seeing an increase. And June of 2020, which is the first virtual meeting that we're able to show on this graph, there is a huge increase in participation, which was maintained in September 2020. So in-person meetings do allow for some networking activities that virtual meetings do not, but virtual meetings allow members to participate who can't gather in person, where it's not feasible for them to go to Harrisburg for a full day. And that might be a really important advantage to participation and engagement. So we think that the PCC should consider continuing virtual access, even if someday we are able to return to in-person meetings, which do have some other benefits. These changes in accessibility might mean that there's an opportunity to recruit new members who weren't able to get there in person before or found it a barrier. But the PCC might need to find new ways to sustain networking and other activities that in-person meetings fostered that these virtual meetings aren't quite as good for. So our fourth finding was that survey participants reported perceiving a variety of benefits from their PCC membership. So we had a list of statements about benefits, and we've arranged them in order of how many said that they were very important or for a level of 4 or 5 in importance. So we found that people felt quite positively about the benefits and their importance, and that more than 90%, nearly 100%, said that being part of an effort to improve cancer outcomes in Pennsylvania was very important to them. 98% had a 4 or 5 for staying well informed. 90% said that developing collaborative relationships and opportunities was important. And 90% agreed that their involvement in the coalition helps them learn about cancer disparities in Pennsylvania. And below that, developing professional networks, enjoying collaborating with fellow coalition members, helping my own organization move forward, and my work with the coalition aligns with my work within my own organization. So a majority felt that these were a 4 or 5 in importance to them. But it is worth noting that the 2 statements about their own organization are at the bottom, which means that members might at times experience some level of conflict between their need to do due diligence for their organization's interests versus the PCC when there's a conflict with time availability, for example. And again, this is something that's very normal to see in coalitions, but it is something to kind of be aware of, that those conflicts exist, which I think we all are aware of. And one thing that we can think about is how to use these benefits that so many members overwhelmingly say are 4 or 5 in importance, to try to attract new members. Also, I wanted to point out that many of these benefits are related to communication. So being aware of communication, trying to continue to update the website, using other communication channels to enhance these benefits will also help keep people engaged. And if those benefits are what's important to them, then it will help us with engagement. So sharing cancer-related news and updates for Pennsylvania, providing links to data and other relevant resources for PCC members is also great. I think that Nathan's presentation today is because exactly the feedback that we got about this. So thank you, Nathan, and everyone for making that happen. And I think the PCC website is still underused. So one thing that we can do is try to continue to promote it for ongoing updates and communication between meetings. Our 5th finding is the responses to a list of potential barriers do reveal some areas for growth or some things that we might be able to handle. Again, these barriers are pretty normal for coalitions, but we wanted to ask folks about them. So this first page of barriers, these barriers weren't very important. Most people reported that they weren't a barrier at all, or at most gave them a 2. So I'm going to skip in the interest of time to the next one. These 3 barriers had a little bit more toward the dark red end of the substantial barrier. Okay. So one of these is that the logistics of attending in-person meetings are moderately to substantially difficult for about 1/3 of the people who participated in the survey. So that's not a ton of people, but if that's people who participated in the survey, then it's a fair bet to suggest that there's probably other people who aren't PCC members because that was a barrier to them participating. This goes to the earlier recommendation to continue virtual access. Another barrier that's really important is that I don't feel like we get anything done, or I feel like there's a lack of momentum. And my time and skills are not well used. These to me are a little bit like they're kind of getting around the same thing, that it's not always worth the time or that it can feel frustrating. So we need to find ways to address these issues. Again, these barriers are normal challenges of being part of a coalition. We can try to work on ways to link members to opportunities to be more active in the PCC for those who want to be, and ensure that folks are linked into the work groups that are a good match for their interests and skills. Working on communication might also help some of those members feel connected to the larger impact on cancer control and make it feel like it's worth it and less frustrating. And our final finding that I want to talk about is that participants suggested access to data resources and funding opportunities would be the most useful addition to the PCC website. So we asked what resources would be helpful on the PCC website, and these were the results. So the number 1 was linked to national and local data sets. And that was also resources for data analysis and visualization was number 3 on the list. And then funding opportunities was another theme. And then resources for how to reach people that are unscreened or hard to screen, how to implement health systems interventions, so intervention toolkits, mapping resources, and then as it gets down, access to literature, guidebooks, advice for funding. So these are some examples of things that we could do to enhance the PCC website. So PCC leaders and workgroup subcommittee members should continue to share and remind their groups what resources are available on the PCC website and where they're located, how to get to them. And we might want to also think about how to create a way to share cancer-related funding opportunities with PCC members on a regular basis, if that's something that funding announcements beyond just state funding are things that would be beneficial to share. And we might also want to consider how to encourage partnerships among PCC members so that they can go in to make grants together. So there were some emerging themes that were in common among these that I kind of pulled out. So the first one is a need to continue to enhance communication with and between PCC members, which also includes enhancing access to grant opportunities, cancer news, data resources, intervention toolkits, etc. on the PCC website. The second one is that the PCC needs to continue to strategically recruit new PCC members as recommended by the members. So we could also consider enhanced membership records to track our progress in that project. The third one was continuing to strengthen new member onboarding and consider mentoring or buddy system to enhance engagement and comfort with the PCC. Again, this is a normal thing. Coalitions are complicated. There's a lot going on. We have a multi-sector coalition with hundreds of people that are engaged in it in some way. And so it can be a lot to navigate in and find one's place when one is new. But it's also really important to ensure that new members are able to find that place so that they can contribute. The fourth thing is that we think that we should consider to make meetings virtually accessible, even if we are able to gather in person again, and to consider ways to enhance member interaction, to think about how we can replace some of the missing in-person opportunities for more casual networking and getting together. The fifth one is to continue to work on clarity of roles and responsibilities, including within work groups, so that people feel like they have a voice and that what they're doing makes a difference and that we're moving forward. And finally, continue to foster these multi-sector partnerships between PCC members and non-members, especially other state agencies, to support the health of Pennsylvanians. So that's what I have. Thank you so much. I have 3 minutes left if you have any questions or critiques. I'll stop sharing. If anyone has additional questions about anything that they want to follow up with me later, I'm happy to talk to anyone about it. Or if anybody wants, I forgot to put a pitch to join the evaluation subcommittee on, but if anybody wants to join the evaluation subcommittee, we would love to have you.
All right, if we don't have any questions, I think we can go ahead and move on. Kate, if you want to move to the next slide.
Absolutely.
And so I'm going to turn it, thank you, Heather, for that. I'm going to turn it over to Kate and Lynn to describe what will occur during this afternoon's PCC session.
Thank you, Kelly. I want to thank also all of our morning speakers for just amazing content and really great conversation in both the coming off of mute of our coalition members as well as through the chat. It just really is very reflective of just how we are doing this incredible work together, how we are continuously brainstorming and challenging ourselves in this space to do more for our communities across the state. In thinking about this afternoon, what we really wanted to do as we're winding down this 2020 year is sort of continue this morning's conversation in that package of the PCC meeting. So we do really encourage our morning members to continue on this afternoon, as instead of some of our more traditional meetings when we were in person, we are going to do this as a singular meeting. But what you will be hearing from are many of our work groups, and having the opportunity to not only hear a little bit about what's going on, some highlights that they want to share, sort of that continuation from some of the good content you heard in September, but also to have some discussion. So as you had heard from Heather's sharing and some of the recommendations and feedback that we've heard through the survey, you know, hearing about what the work groups are doing, we wanted to give this space to dialogue together, to hear together, and to kind of go even on that theme, revisiting some of that kind of who we are and the structure and all of that good content. We will be doing that too. So there'll be a continuation also of some data conversation and some of our survey conversation in a just more dialogue fashion. So that is what this afternoon really will be. So we will again encourage everybody to come back and be a part of that conversation, and really do look forward to that. And Lynn, before I turn it back to Kelly, oh, what's that? Oh, I'm sorry. I thought somebody had a comment. And before Kelly, I kick it back to you, Lynn, is there anything else that you wanted to add or anything I may have missed?
No, Kate, I think you did a good job, but I think it's really critical that people do return this afternoon, because for someone who's been involved about 10 years now, I have seen so much movement in the right direction over the years, but it takes all of us, and it really takes conversation, communication, and working together, and learning from each other. And I think we have to do that within the groups and with, you know, in between groups, and also with some of our subcommittees. So hopefully we'll be able to achieve that this afternoon.
Absolutely. And this question just came from the chat, so I'll address this right away. So thank you. This is the same link that you would stay on, so you can, you know, when we do break for lunch, kind of in a virtual space, you can stay on here or just return to the original link to come and right back into the same meeting. And so even this afternoon, we can talk a little bit about what 21 will look like in the kind of virtual world and things we're looking forward to bringing to our coalition, as we kind of continue on with, again, some of the feedback we have heard and some of that value that we are finding in a virtual world. So yeah, so you can continue on with this link. You can stay on, or you can kind of log off and then log back on. But again, as Lynn mentioned, really critical. We're hopeful for you to stay on, and, you know, and thinking about just this year in particular and what we may expect from 2021, hard to believe it's right around the corner, is that I'm sure many of us, if not all of us, have been stretched in new ways, but also really challenged to go even deeper and have just incredible conversations and look at things in a new light. So, you know, we're encouraged to continue to do that, looking forward to that, and really thinking in how we not only tap into those resources that we all have as a coalition, and really think about the work that we are doing and how we want to do that as we move forward with COVID-19 as it affects our cancer community. So, you know, I'll turn it back to Kelly at this point to kind of take us to our official break, and look forward to seeing everyone this afternoon. Kelly, I'll kick it to you.
All right, thank you, Kate and Lynn. So we will be adjourning the CAB as we talked about. I do just want to take a moment to thank everybody for their participation today. We had great presentations. We were able to move things along nicely. We had a pretty full agenda, but it looks like we're going to end with a couple minutes extra for your break. So I do encourage everyone to, if you're able, to join this afternoon's PCC meeting. And so thank you all for your attendance today.
Great. And Kelly, this is Aurelia Dominic, CAB member, and
Yes.
I'd like to make the motion to close the CAB portion of the meeting.
Thank you. And do I have a second?
This is Pat Halpin Murphy. I second that motion, Aurelia.
Thank you so much.
Yes, thank you to both of you. And we will reconvene at 12:30. The CAB meeting's adjourned. Thank you.
Very good. Thank you.
Thank
Bye-bye.
you, Kelly.
Thank you.
Everybody was terrific today.
I agree. Thank you. So good to hear your voice, Pat.